So my name is Dr. Saud Iqbal. Assalamu alaikum. So let's start about cardiac tamponade. So what is cardiac tamponade? Cardiac tamponade is a fluid collection, around the heart, specifically pericardial space, around the pericardial space. Pericardial space is called cardiac tamponade. So what's about the normal heart? So let's discuss about the normal heart, the visceral wall, the parietal wall. So look at this. So let's assume that there is our normal heart. There is a right atrium, there is a right ventricle, there is a left atrium, and there is a left ventricle. So this layer, which very close to the heart chambers, this layer is called visceral layer. What is called this layer? This is called visceral layer. So there is another layer. There is another layer which is far away than visceral layer. It is called parietal layer. So in the surrounding structure in the heart, there is a two layer. One is visceral layer and another is a parietal layer. So this one is a visceral layer and this one is called parietal layer. So what happened in the parietal layer? So if there is a penetrating trauma or infection, or autoimmune disease like SLE, pericarditis, or post-TB disease or reinfection, there is a fluid accumulation start to the pericardial space. So there is a fluid accumulation start to the pericardial space. When the fluid is accumulated to the pericardial space, now this fluid normally that is not written to the book, but let's assume that normally there is a 20 to 30 ml fluid in the pericardial space, 20 to 30 ml. What happened in the cardiac tamponade? In the cardiac tamponade, there is a more than 300 ml fluid accumulation, more than 300 ml fluid accumulation in the pericardial space, more than 300 ml accumulation in the pericardial space. So this is pericardial effusion occur. If fluid is little accumulation, for example, fluid is 80 ml fluid accumulate in the pericardial space, so we call is pericardial effusion. This is a huge difference between the cardiac tamponade and pericardial effusion. What is difference? If the fluid accumulate 80 ml, less fluid accumulate in the pericardial space, so we call is pericardial effusion. If fluid accumulate 300 ml, so we call is cardiac tamponade. So if we left untreated the pericardial effusion, if we not treat it well, so in the complication of pericardial effusion, there is a cardiac tamponade occur. So there is a cardiac tamponade occur. So let's back to our diagram. So this is our diagram. Left atrium, there is a right atrium, there is a right ventricle. This is a left atrium, there is a left ventricle. So we said that there is a fluid accumulation in the pericardial space. Now we see that that in the superior vena cava drain into the right atrium. So internal jugular vein. If the fluid accumulation in the all chambers of the heart, they will compress to the heart. So the heart cannot pump blood to the whole body. So the cardiac output, so the stroke volume will decrease, cardiac output will decrease. So if there is a blood that will accumulate here. So jugular venous distension occur. So when the jugular venous distension occur, so now there is a important point. What important point? The important point is that increased JVP is a classical sign of cardiac tamponade. So JVP occur. Now if the blood goes to the systemic circulation, so there is decreased blood goes to the systemic circulation. Now the systemic circulation BP will be dropped. So there is the triad occur. What triad occur in the cardiac tamponade? There is a triad occur. So number one, raise JVP. So number one, raise JVP. Number two, there is a decrease blood pressure, so hypotension. Number two, hypotension occur. And the third one is muffled heart sound. So what the reason behind the muffled heart sound? If we auscultate the heart, so we we can hear the muffled heart sound. So what is muffled heart sound? The muffled heart sound, so let's begin to our diagram. The muffled heart sound, if the fluid accumulate here, the heart will abnormally produce a sound. So that abnormal sound we call as muffled heart sound. Abnormal sound of the heart we call as muffled sound. So let's begin to our notes. So in cardiac tamponade, there is a life-threatening condition in which accumulation of fluid in the pericardial space, leading to increased intra-pericardial pressure and compensated heart and compromised heart. So according to the definition, pericardial fluid accumulation under pressure compressing the heart chambers, particularly right ventricle, leading to diastolic filling, reducing cardiac output. So we move on. So what is the cause? The cause is the trauma. Let's assume that there is a heart. So any trauma which penetrate the injury, for example, straight wound, blunt chest trauma, pericarditis, myocardial infection. What is pericarditis? Pericarditis is an inflammation of the pericardial space. Inflammation of the pericardial space is called pericarditis. So pericarditis, myocardial MI, post-MI heart attack, malignancy, uremia, connective tissue disease, SLE, post-SLE mean systemic lupus erythematosus, post-cardiac surgery, aortic dissection. So mechanism, fluid volume increase, as I said earlier, intrapercardial pressure rises, leading to impaired ventricular filling during diastole. This decreased stroke volume, cardiac output, resulting in hypotension and shock. So what's the difference between pulmonary pleural effusion and cardiac tamponade? There is a shock. So here is a Beck's triad, hypotension, distended neck vein, and muffled heart sound. So resulting from fluid damping the heart. What is the muffled heart sound? Fluid damping the heart, leading to heart failure. Pulsus paradoxus. So what is the additional sign? Additional sign is that according to a triad, which is above the signs, addition of the signs, there is a VC, the cardiac tamponade. So what is additional sign? There is a pulsus paradoxus. What is pulsus paradoxus? A fall in systolic BP greater than 10 millimole Hg during inspiration. And tachycardia, compensatory mechanism due to reduced cardiac output. Chest pain, sharp, pleuritic, worsen with breathing or lying flat. Dyspnea. So what's the mechanism of the dyspnea? Dyspnea, for example, this is a heart and there is a lungs. So in the heart there is a fluid accumulation. So the cardiac output is reduced. So in the pulmonary arteries, the fluid is not going to the lung. So in the lung there is a no gaseous exchange, and in the no gaseous exchange there is a dyspnea occur. So this is a mechanism of the dyspnea. So this is a sign of shock. What is the sign of shock? Cool, clammy extremities, altered mental status in severe cases. So ECG is in investigation we do ECG. So in investigation, first of all we check BP. If less than 60. So in BP we see there is a hypotension. Then we auscultate the heart and we see the muffled heart sound. Then ECG, low QRS complex and electric alternance we see. In chest X-ray we see there is a water bottle appearance. What is water bottle appearance? For example, this is a heart and they look like a water bottle because of fluid accumulation. Enlarged cardiac silhouettes. So cardiomegaly, there is a heart failure, a fluid overload. So if within the heart chamber the fluid is accumulated, so we call as cardiomegaly and the heart is enlarged. If outside the heart and the pericardial fluid is accumulated in the pericardial space, so we called as cardiac tamponade. If greater than 300 ml, 250 ml, so we called as cardiac tamponade. If 80 ml, we called as pleural effusion. So in hemodynamic, as earlier I told you that right heart catheterization show equalization of diastolic pressure in all four chambers. So hemodynamic parameters overlap with other causes of shock. For example, in this cause of shock, diastolic pressure, if we catheterize the heart, so we see that there is a right atrium, right ventricle, left atrium and left ventricle pressures are equal, are same. So because there is a less pressure, so we see there is a in cardiac tamponade hemodynamically monitoring, there is a equalization of diastolic pressure is equal. So that's it. Now in the treatment, what is the treatment and differential diagnosis? So the differential diagnosis, we come to differential diagnosis. So what is constrictive pericarditis? So in the constrictive pericarditis, we seen that there is a Kussmaul sign. What sign? There is a Kussmaul sign. So Kussmaul sign, what is Kussmaul signs? In the Kussmaul sign, we see there is a raised JVP on inspiration. Raised JVP on inspiration. We see a Kussmaul sign, there is a raised JVP on inspiration. So pericardial knock, Kussmaul sign, pericardial knock across all chamber without pulsus paradoxus. So in tension pneumothorax, there is a chest problem, lungs problem, and trachea shifted away from the affected side. So in the tension pneumothorax, what causes? So there is a penetrating trauma, etc. वगैरह. So in the tension pneumothorax, we immediately do pericardiocentesis. In pulmonary embolism, there is a sudden pleuritic chest pain. So sudden pleuritic chest pain plus factor of DVT, D-dimer test is positive. So what is the investigation of choice? In pulmonary embolism, there is a CT pulmonary angiograph. So in cardiac tamponade, there is a muffled heart sound and hypotension and raised JVP. In pulmonary embolism, sudden onset pleuritic chest pain occur. In acute right ventricular myocardial infection, what happened? In acute ventricular right myocardial infection, there is, so let's see this. So in acute myocardial right ventricular infection, if there is MI, so what seen here there? Elevated JVP, clear lung, ST segment, raised ST segment seen in V4, V6 leads. So we see that if the raised ST segment seen in ECG, so we call as acute right ventricular myocardial infarction. So there is a difference between AVRI and cardiac tamponade. In severe aortic stenosis, so in severe aortic stenosis, there is a dyspnea, syncope, exertional chest pain, systolic murmur radiating to carotid. So there is a look for chest pain, systolic murmur radiating to the carotid. So pulsus paradoxus and JVP are not typically present. They are typically only present in the cardiac tamponade. So in the cardiac dilated cardiomyopathy, so there is a, in the dilated cardiomyopathy, there is a sign of heart failure, means there is a dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. In night time, there is a chest tightness and shortness of breath and displaced apex beat. So we differentiate this from the cardiac tamponade. So in the restrictive cardiomyopathy, we look for right-sided heart failure and normal ventricular size. But in the cardiac tamponade, there is a ventricular size is diffuse, and there is a no pericardial effusion. But in the cardiac tamponade, there is a pericardial effusion is present. As I told you earlier, that pericardial tamponade and pericardial effusion, what is the difference? So water bottle appearance are seen on chest X-ray. So there is a we call as cardiac tamponade. But a hemodynamically stable patient, so if hemodynamically unstable patient, so we call as there is a cardiac tamponade. If he